of time, we have to move on back to Dr. VIKAS Menon, and let's hear about what he has to say about Mitomycin C in DCR.
Hi, good evening, everybody. Can you see my slides? Hello?
Yes, Dr. VIKAS, we can see your slides. Please go ahead.
Okay, so how do I go to that? Just a moment. Yeah. Yes. So I'll be talking about Mitomycin C in DCR. First disclaimer is that whatever I'm going to say is extensively copied from Dr. Javed and Dr. Akshay's work, and I know they're nice chaps, so hopefully they won't mind. So from all the preceding lectures, what we have understood is that DCR is a major surgery. It is in no way a minor surgery for which you have to really prepare a lot. Pre-op evaluation, a lot of systemic evaluation you do, and then you have to struggle to maintain hemostasis during the surgery also. And patient also has to undergo some pain under local or has to undergo GA procedure. And what happens if subsequently that procedure fails? Now that is something really painful for the surgeon as well as the patient. And that's really very unpleasant for all the parties involved in this. So we know that, DCR failure happens most commonly because of the blockage of ostium that we have created. Now, what causes the blockage of that ostium is granulation tissue or scarring. That's basically the body's own response itself to the trauma that it has undergone during surgery. And also, many times, if our technique is also not, up to the mark, then sometimes we end up injuring the nasal septum, nasal mucosa in certain ways, or maybe using more of cautery and causing more of necrosis and leading to adhesions of synechia in the nasal cavity, which can also contribute to the failure of our procedure. And the reported failure rate has been documented to be about 0 to 18%, both external and endonasal route. Again, quoting from Javed and Akshay's work. So we all, as ophthalmologists, have been exposed to using Mitomycin C for a long time. We've seen our seniors and a lot of older glaucoma surgeons use it in TRAB for a long time. And nowadays, corneal surgeons are also frequently using it. And we have also now been using Mitomycin C for a long time in DCR. We know that it's a systemic antibiotic which is derived from the filamentous bacteria Streptomyces cespitosus. And what basically it does is it targets fibroblasts. So fibroblasts, as we know, that are the key cells involved in causing scarring and closure of the ostium. So here we have an agent which acts on these fibroblasts and inhibits the synthesis of proteins and inhibits the synthesis of collagen by fibroblasts through various ways. And then it inhibits fibrous tissue growth and scarring in the ostium. The advantage of this drug is that it's a fairly cheap drug. You get it for almost about 200 rupees, and you can dilute it in normal saline, and you can even store it in at room temperature for up to 48 hours, and it remains stable. So that is another quality, that even in economically challenged situations, you can still go ahead and use it. And there is plenty of evidence. There is plenty of evidence which points towards the utility of Mitomycin C during DCR surgery. And there have been randomized control trials. There have been various meta-analysis. And so you just have to type Mitomycin C in DCR in PubMed, and you will come to know of the large number of studies which have already been done. So there is no excuse nowadays to not use this drug. It's been proven that, it is useful. And there has been no study so far which has shown that, any disadvantage of using it. Any study which shows that the success rate has gone down after using Mitomycin C. So that has not been the case. It has always, in whatever studies we have come across, it has shown to increase the patency of the ostium or increase the chances of the ostium being patent. So another question was, what is the ideal dose and for how long should we keep it in place? Right. Now, again, Dr. Javed has solved that problem for us. So he conducted a basic study on fibroblasts of nasal mucosa and found that any dose which is more than 0.5 milligram per ml is lethal and causes extensive cell death, or any concentration more than even up to 0.4 milligram per ml, but if used for more than 5 ml for more than 5 minutes, can cause extensive cell death. Now, what happens is if there are more cell death, what will happen? There will be more tissue necrosis, there will be more subsequent fibrosis, and there will be more irregular healing, which can impact your osteum. And they also found that the minimum effective concentration seems to be 0.2 milligram per ml for 3 minutes. So what I use at present is 0.4 milligram per ml for 3 minutes. That is well under 5 minutes in adults. And for pediatric cases, I use 0.2 milligram per ml for 3 minutes. So this is my preference, but Javed has shown that 0.2 milligram per ml is also good enough. This is just a brief video for people who may be wondering that, who heard about mitomycin, but wondering how to use it. So you take these sponges, these Merocell sponges which come, and you insufflate them with Mitomycin C. 0.1 to 0.2 ml will go into one of these. You take 2 of them, and when you are at the stage where you have created the flaps, the sac and the nasal mucosal flaps, you created the ostium. So you put one by one these 2 Merocell sponges in the ostium, right? And you make sure that your flaps are lying over the sponges, and then you leave it in place for about 3 minutes. That's it. Once 3 minutes are over, you retrieve your sponges, and then you irrigate the area with normal saline, and you wash it properly. I also tend to wash the skin wound also properly after using mitomycin, just in case, there is some delayed healing or something. And some surgeons are there who do not prefer to irrigate also, but that also seems to be working fine. So that's an individual choice probably. And then you just close your flaps over it, and the skin and orbicularis the usual way. So that is how you apply Mitomycin C in your ostium. It's pretty straightforward, simple technique.
1 minute left.
Okay. The other described methods which have been described are circumostial injections. Again, Dr. Javed, I will quote here, who has described circumostial injections in certain situations where he feels that, there is chances of more scarring. So you inject mitomycin directly into the nasal mucosa, and you can repeat those injections also subsequently. So he's found that, that the results are superior. There have been reports of 2-stage application of Mitomycin C, one intra-op and another application subsequently at week 1, 2, or 3 through with a cotton pledget into the nose endoscopically, and that has improved the situation. Some surgeons have described post-op MMC soap nasal packs for about 24 hours. So there have been different ways in which Mitomycin C has been described. So what do you do is actually up to you, but one thing is clear, that using Mitomycin C in some form helps to improve the efficacy of your DCR. It helps to prevent closure of the ostium. Talking at the end about contraindications and side effects. So to date, there have been no direct complications which have been associated with the use of the dose of Mitomycin C that we use in DCR surgeries. And whatever contraindications we know are from the systemic literature. If there is a history of hypersensitivity reaction to any drug, you don't use that drug. That is basic. And patients with high serum creatinine, you don't use Mitomycin C. Coagulopathies, bleeding diathesis, we prefer to avoid. Severe immunosuppression, you avoid. Now, again, this is again related to the systemic dose, which is very high when used in cancers as an anti-cancer drug, but better to avoid. Why to take a chance in such cases? And also in pregnancy and ladies who are breastfeeding, so you avoid using Mitomycin C, as it is not recommended for pregnant women and for feeding women as well. So to conclude, it is a well-proven adjunct to surgery, and all DCR surgeons should be familiar with using this useful medication in most, if not all cases. So I specifically did not put any slide for indications of Mitomycin C because for me, I use Mitomycin C in all my DCRs. So there is no specific indication, but if somebody were to pick out few indications, then obviously pediatric group, post-trauma group, and anywhere where you, or a failed DCR, wherever you are anticipating more scarring, you could go with them if you are going to use it selectively. But if it's a major surgery, patient is coming to you one time, and the repeat surgery does not have that good an outcome. So why not give our best to the patient in the first go itself? That is the whole point. Thank you very much.
Thank you very much. Have you had any problem by use of mitomycin in the surgical site, like, in a glaucoma surgery, the blood can become very cystic and all that? Of course, there are other reasons also for being cystic. Now that you place the pledget posteriorly in glaucoma surgery, we don't get those kind of cystic blood. So that way, is there anything of practical tip about mitomycin? Nothing at all?
No, we haven't had any problems with using Mitomycin C for 3 minutes whenever we are using in osteum. So far, there hasn't been any problem.
Okay, right. Thank you. Dr. Arvind, you could stop sharing. Wonderful talk. Very crisp and